Good afternoon and welcome. We're so excited to be here with you today. I'm Dr. Fazane Sabi, OBGYN and Associate Medical Director at Kaiser Permanente Mid-Atlantic States. I am so excited to share this session with you today on a topic that is near and dear to my heart: musculoskeletal, foot and ankle conditions and injuries in first responders, military service members, and veterans. It's interesting, as I was thinking about hosting this session and talking with some of my colleagues, there's a lot of interest in just back pain, chronic pain, and foot and ankle health, especially in occupations where people have to work a lot on their feet, wear either combat boots or certain types of shoes that tend to cause more irritation and pain. And so I am so excited to share this session with you today. I would love to welcome our next speaker, our first speaker, Dr. Gregory Kahn Arthur, who will share his insights with us on musculoskeletal health.
Great, thank you, Fozzie. Thanks for that great introduction. I'm Dr. Gregory Kahn Arthur, and I'm a pain management specialist here with the Kaiser Permanente. Today, first of all, thank you for joining this very special presentation to discuss musculoskeletal injuries in our military and first responder populations. It's especially exciting to have our Facebook Live audience joining us today, along with many physicians and nurses from Kaiser Permanente. Next slide, please. Thank you. So today I'm going to do my part to introduce the concept of the tactical athlete and explain musculoskeletal injuries in context for this very special population. We'll also identify some common patterns of musculoskeletal injuries and the unique approach taken in this population. Next slide. So let's start with what exactly is a tactical athlete. Well, many of you listening right now may be considered a tactical athlete. This includes our military service members, law enforcement officers, fire service professionals, and as well as veterans of these professions, and many others whose physical conditioning, training, and performance are an integral part of the work they do, much like athletes. But the tactical part implies that the work they do is dangerous, sometimes life-threatening, and requires regular training and maintenance of resilience to perform this work. Unfortunately, this often means a higher likelihood of musculoskeletal injuries due to this work or in training for performing at such a high level. And I'd be remiss to neglect the fact that people in these professions experience some of the most difficult situations a human being should face. And they do so willingly in an effort to come to the aid of others. So emotional and moral injury is also significant and worthy of consideration because it can certainly cause the pain of a musculoskeletal injury to become more persistent or chronic and difficult and complex to treat. Next slide, please. So here you see three examples of tactical athletes. And important to note is that each of these professionals is wearing their professional kit, a term for equipment and protective clothing or armor. On the left here, we have a United States Air Force JTAC, Joint Tactical Air Control Party. He's essentially a one-man air traffic controller, a special operator, and one of the most highly trained military professionals out there. He would go out with his joint service brethren like the Rangers or special warfare teams and others to ensure that they have coverage, air coverage and support for things like fires, medical evacuation, and reconnaissance. His kit, as you can see here, includes that ballistic vest, many pouches, ammunition, very specialized radio equipment, that sort of thing, his helmet, and often he would also be carrying a weapon of some sort and a belt around his waist. Now his kit can weigh about 45 to 75 pounds, depending on what he's carrying that day. And if he has a pack, it could even top about 100 pounds in addition to his body weight. And in the middle here, you'll recognize that's a fire service professional, a fireman, with his kit. Which can sometimes weigh like what you're seeing here, maybe about 75 pounds, but can certainly weigh much more depending, again, on the equipment he's carrying, maybe the air tanks that they're carrying, things like axes, special equipment for extrication or access, that sort of thing. And the police officer, as you can see here on the right, with his gun belt, camera, sometimes they carry chemical masks, ammunition, that can certainly weigh upwards of 45 pounds as well. This adds not only weight to all of these service professionals, but also thermal stress on the individual wearing the kit, and can make moving around in the tactical environment very, very tricky. So think about having to clear a burning building, chase and subdue a violent offender, or jump from an aircraft 16,000 feet in the air, land and do battle with an opposing force, all while wearing all of this equipment. That's a very hard task for anybody's body to do. Next slide, please. So this diagram points out, oh, I'm sorry, that's the next slide. So this diagram here from the Journal of, from the RAND Corporation, sorry, points out some very important aspects of musculoskeletal injuries in the military population, but can certainly apply to all tactical athletes. Almost half experience chronic pain sometime in their career, most if we're being honest, and musculoskeletal injuries represent the most common causes of injuries in this population. It's the most common reason for limited duty and disability, including shortened careers due to early retirement or medical retirement. And it's mainly the non-combat or direct action activities that account for these injuries, including training, exercise, recreational activities, and sports. Next slide, please. So this diagram from the Journal of Science in Medicine and Sport shows how exposure to physical activity, including its frequency, intensity, timing, and type, can help or hinder a tactical athlete depending on their individual circumstances of things like environment, their physiology, their medical conditions, their usual workload, and overall body dynamics, including things like nutrition and what supplements they're using and what medications they're on and that sort of thing. So developing a fitness regimen that optimizes function and ability, but without causing harm, is something every tactical athlete needs to be aware of and consider. Because without proper guidance and help from medical professionals and people like trainers and physical therapists, sometimes in preparation, doing a lot of different exercises, the frequency of those exercises and such can actually start to cause micro trauma or harm for these tactical athletes. So for the docs listening out there, it's important to have this concept in mind, because when you are considering profiling or limiting the duty, or providing reasonable accommodations, exercise prescriptions, that sort of thing to a tactical athlete, you have to be aware of what that member's job is and have some familiarity with what they're expected to perform and under what circumstances, what kind of kit they wear, that sort of thing. So it helps to have that conversation and ask these kind of probing questions about their job, their equipment, that sort of thing, because it'll give you a very good sense of how to adjust things like the frequency, intensity, timing, and type of physical activity that person is supposed to be performing, and what they can perform in order to prepare for their job. So next slide, please. So getting into care, what we can see here is the most common types of musculoskeletal injuries and frequent causes. The vast majority is microtrauma from training and regular hard use of the body, things like load bearing and other stresses. And some of the protective factors are not what you might think. So for example, here, increased aerobic capacity, I think that kind of makes sense, that the better fit you are in terms of aerobic capacity, the lower your injury risk. However, it's interesting that people with the lower body mass indexes, the lower weight and body mass index measures tend to have the higher injury risk. And certainly that might not be very intuitive, but it kind of speaks to the fact that the higher your body weight, the more robust your body is and the more you're capable of bearing loads and things like that. Whereas if you're a lower body mass index, you might be more susceptible to things like strains and sprains and tears. So some of the leading causes that are mentioned here are associated with things like running, duty-related tasks, of course, falls are a big one, and of course, sports participation. And in this chart here, you can see that lower extremity injuries are especially frequent in the tactical athlete. Next slide, please. So the care that these professionals receive should always include some form of non-pharmacologic therapy. Too often, tactical athletes and even physicians want to get back out there or get that service member back out there so that they're able to accomplish their mission or do their job. So they often try to resort to quick fixes or medications or sort of a magic pill concept that, oh, if I just take this to cover up the pain of this injury, then I'll be good to go. I'll be able to get back out there. But that can often work against you and lead to even more injury. The real solution lies in things like physical training, physical therapy, occupational therapy, thoughtfulness in making exercise prescriptions or plans, and alternative modalities, things like acupuncture, even things like pain psychology, which many professional athletes use on a regular basis in terms of mindset, and also things like biofeedback. But unfortunately, a lot of these non-pharmacological therapies are pretty rare and often not offered right up front when somebody has a musculoskeletal injury. But it is increasingly available in places like the VA, for example, service organization training rooms like in police departments or in the military, and of course, here at Kaiser Permanente. Next slide, please. And I'll also mention opioid use in the tactical populations. So typically for things like musculoskeletal injuries, opioids are certainly not usually the first line. We don't usually use opioid analgesics or pain medications of that nature first off when somebody has a musculoskeletal injury. But of course, with things like fractures and serious injuries, that is of course appropriate, but we want to try to limit the use of these special class of pain medications because physical dependence can certainly rear its ugly head and lead to more chronic pain and even more pain, heightened pain over time during the healing process. Opioids are usually considered duty limiting for most tactical professionals. So if you're taking an opioid, chances are you're not able to do your job. And that's very counterproductive, of course. I think in the tactical professions, things like anxiety, depression, PTSD seem to have a higher prevalence, and things like opioids can certainly make those conditions worse. So we want to try to avoid using these as a first-line treatment. Many military treatment facilities and VA medical centers and places like Kaiser Permanente have very structured opioid stewardship policies and practices, where we are very careful with considering the risks versus benefits of using these medications. And you'll find that most places that have these approaches tend to be far more successful in preventing chronic pain and helping people to recover quicker. We also have lower rates of things like addiction and chronicity of pain and development of new kinds of pain like nerve pain and headaches and things like that after something like an ankle sprain or a fracture. And of course, for the docs listening, many times if somebody is not getting the care that they feel they want or need, and they really want to get some stronger pain medication, sometimes they will not be offered that in the places like the VA or their service medical facilities. And they may come to the civilian providers to try to sometimes get a secondary or outside referral to get a quasi-illicit route to obtain these substances. That's always something to consider. Certainly, we want to use these medications when appropriate, but if they're coming in for a second opinion and you know that they're being treated by their service organization or a physician in the VA, for example, it pays to reach out and talk to that other medical professional to see what's going on. And next slide, please. So with that, I will pass it over to my colleague, Dr. Christy Golden, who will discuss some of the most common musculoskeletal injuries in tactical athletes, lower extremity injuries.
Hello, thank you, Dr. Conarthur. Great job. Okay, so I'm a podiatrist. I treat all ailments of the foot and ankle, and I'm here to talk about some common overuse injuries in our first responder population as well as our military and veteran populations. So next slide, please. So our learning objectives today are to identify foot and ankle conditions that are commonly found in first responders, military professionals, and veterans. And these really fall into two buckets, overuse injuries and traumatic injuries. So I'm going to be talking about overuse injuries. And then my colleague, Dr. Shoup, will talk about traumatic injuries of the foot and ankle. And we'd like to develop screening and diagnostic approaches for this population in terms of foot and ankle health. Next slide, please. So overuse injuries. The first one is plantar fasciitis and Achilles tendonitis. These are very common conditions in all populations of people. And really, the plantar fascia is a ligament. It's on the bottom of our feet. It's attached to the bottom ball of the heel, and it extends underneath the skin to attach to the toe area. Think of it like the bottom of the arch, the support structure of the arch. And so people with plantar fasciitis will complain of pain at the bottom of the heel where the heel strikes the ground. And Achilles tendonitis is actually inflammation of the Achilles tendon, which is the tendon on the back of our calf that attaches to the back of the heel. And people with Achilles tendonitis will complain of pain at the back of the heel where like a shoe would rub. Both conditions are usually worse with increased activity, but also can be when the patient just stands up to start walking after a rest. That's very common first complaint of both of these conditions. The first step of the day, first step after a long drive, first step after getting up from my desk at work is very painful. So I always say there's a reason that we could come up with for every single person to have a bout of plantar fasciitis, but generally it's weight gain or just being of a higher weight for a long period of time. Carrying heavy objects like what Dr. Conarthur was talking about, all those kits and how much they weigh, that's a big predisposing factor to have flare-ups of heel pain. And abrupt changes in activity levels. So if someone tells you, I'm really motivated right now and I've been exercising 3 to 5 times a week and I hadn't done that for years and now my heel is very painful, that's a very common story for plantar fasciitis for sure. And then lack of arch support. So all things that are bearing down on our arches, like body weight, what we're carrying, standing and walking for prolonged periods of times, have to be balanced by the shoe that we're wearing. And when we're doing activities that lower our arches, like all those things I just mentioned, we have to be extra cautious of what we're wearing on our feet to make sure that we're providing our feet enough support to withstand that downward force. And so the treatment for plantar fasciitis really varies on the severity, and it's the same for Achilles tendonitis. So in mild cases, when someone's just feeling pain when they first get up out of bed or first a couple of steps of the day that improves after that, and it doesn't really persist all day, it's not causing a limp. but they're coming in for it anyway, then we would really recommend calf stretching. The tightness in the back of the calf and the bottom of the foot is a big predisposing factor for these types of heel pain, because as the arch lowers under those dynamic forces, that plantar fascia, the bridge on the bottom of the foot, gets very tense and it pulls away from the heel bone, creating that pain. And so stretching the fascia with just standard calf stretches and the Achilles tendon stretching will help relieve the pain. And they're both useful in preventing acute flare-ups from coming back and also helping to treat the acute flare-up that they're currently in. Also advising about arch supportive shoes, really thinking about what shoe you're wearing. If you can fold and bend a shoe and twist it, then it's not a good shoe, really for anybody, but definitely for someone who's dealt with plantar fasciitis or Achilles tendonitis in the past. And that also goes for house shoes. I always recommend a good supportive house shoe, which is not like a fuzzy flat slipper, but like an actual supportive rubber type house shoe. I always say your feet don't know if you're home or not, so if you're having heel pain and you're exercising in the best possible shoe, but you're home and you're barefoot on hardwood flooring all day, that could also contribute. And then NSAIDs and physical therapy at home or in the office, and plus or minus cortisone injections in the podiatry department. And then for moderate to severe pain, if the patient's really having pain enough that's causing a limp, it's persistent through the day, it's decreasing their activity levels, they're not able to get through their work day, things like this, then they really need to be immobilized. And so what we do for that is first a cam walker boot, which we dispense in the office, and we recommend wearing that for anywhere between 3 and 6 weeks with every step. And that usually does two things. It holds the foot at an unnatural 90-degree angle, thereby stretching both the calf and the plantar fascia. And it also just immobilizes, it takes the pressure off of the heel so that it can have some time to reduce the inflammation. And if the boot doesn't work, then sometimes we even use a walking cast made of plaster for the foot to better immobilize it. And then the end stage is surgery, which, generally these people do better with conservative care, but there are a small percentage of people that cannot recover from severe or severe plantar fasciitis or Achilles tendonitis, and then we would start to discuss surgery after about 6 to 12 months of failed conservative treatment at least. Next slide, please. The next condition to discuss is posterior tibial tendonitis, very, very common condition. So this is the tendon on the medial aspect of the ankle, just behind the medial malleolus or the medial ankle bone. And so the symptom of posterior tibial tendonitis is pain in that area, medial ankle pain and swelling right along that tendon. Usually when there is a flare-up of tendonitis in this tendon, it's difficult to do a single heel rise, which means if you ask the patient to pick up one foot, the one that doesn't hurt, and have them go up on the toes of the painful foot, it's difficult to do, or they just can't do it. And in severe cases, you might see unilateral arch collapse because that posterior tibial tendon's job is to support the arch. And you can see in that diagram how it does that. It really attaches to the bottom of the arch. So under a lot of downward force, again, those same predisposing factors of changes in our body weight, carrying heavy objects, abrupt changes in activity levels, and lack of arch support. Under that downward force, the posterior tibial tendon fatigues and is not able to pull the arch up against those forces. And so as it fatigues, it gets stretched, it gets inflamed, and it can even tear without an injury. And so in that case, you'll see the arch come lower than the contralateral foot. So treatment again varies by severity. So mild posterior tibial tendonitis, the patient's not limping, but they are having pain and swelling. And if you dig into the history there, you'll probably find one of those predisposing factors that started it. And maybe they're not wearing the right shoe and they just need some shoe advice. Recommending orthotics to put into the shoes to help support the arch. NSAIDs and weight control are always good places to start for mild posterior tibial tendonitis. When posterior tibial tendonitis becomes more moderate, that's when you'll see a limp, like the patient's limping with almost every step, again, not able to get through their workday, not able to exercise, feeling frustrated that they've tried multiple types of shoes and they're still not getting relief. At that point, it's best, again, to immobilize in a CAM boot or even a cast, to give that ankle a rest, to hold it in that rectus posture so that the tendon is no longer doing the heavy work of lifting the body with every step. And that can take anywhere between 4 and 8 weeks of immobilization and anti-inflammatory treatment for the inflammation in the tendon to go away. And then once the posterior tibial tendon's inflammation is decreased and the pain is better, then it's really a conversation about the right shoe going forward so that they don't get a recurrence, which is very, very common. And in severe cases of posterior tibial tendonitis where the patient has been wearing the right shoes, they're wearing arch supports, they maybe have been to physical therapy, they've been immobilized in a CAM boot, they've even tried a cast, and no matter what they do, the tendon is still very painful, plus or minus a small tear on the MRI or bulkiness of the posterior tibial tendon on the MRI, which is indicative of chronic inflammation in that tendon from the pressure of the body weight on there. And then in these cases, we do recommend surgery. But again, after all, conservative therapy has failed because the vast majority of people with posterior tibial tendonitis, once you get to the root cause of it, can get better without surgery. But again, there are that small percentage of people that just can't, and there is surgery for those patients. Next slide, please. And the last overuse condition that I'll be discussing is shin splints. So shin splints are very common in all age groups. You'll have pain along the anterior tibial crest, right where that line is drawn on that photo, and it's almost always worse with activity, as opposed to those other conditions that are with every step. Predisposing risk factors for shin splints are ankle pronators. What that means is if you see someone standing and their ankle seems to be laying on the floor, like the ankle is rolling in, and patients often use that term, my ankles feel like they're rolling in, those patients are prone to shin splints. And then people with flat feet, pes planus, and a lack of arch support are also very prone to shin splints. Treatment for shin splints, generally rice, rest, ice, compression with an ACE bandage if there's swelling in the anterior tibia and elevation. Orthotics, supportive shoes, always super important to discuss. If this is a track athlete, someone who runs a lot, for their job, or they're a military personnel who does a lot of training in combat boots and they suffer from shin splints, which we see very commonly for all of these conditions, actually, because combat boots don't provide a lot of support for those people. We recommend orthotics, customized orthotics to put into their boots. You won't meet a podiatrist in the world who is happy with the combat boot structure. We really would love to see more support in those boots for how much the people that wear them have to do in them. So adding support to them is helpful. And then again, if the shin splints continue to worsen, definitely want to take a step back from activity, immobilize that leg in a CAM boot for about 4 weeks, let the tendon, which is the anterior tibial tendon pulling away from the anterior part of the leg there, rest, and the inflammation to go away. Next slide. Thank you. So this is actually the last condition I'll be talking about today. It is a stress fracture. So stress fractures are very common. Basically, what we're seeing with stress fractures is bone pain. So when you push on the bone itself, it's very painful. Pinpoint bone pain. If you push on it, it hurts right in that spot. And the patient will often point to exactly where it hurts. And it's made worse by weight bearing. No injury history whatsoever. Focal swelling in the forefoot, plus or minus on that. Sometimes there's no swelling. Risk factors for this is really vitamin D deficiency. So I'm big about vitamin D with all of my patients. We're seeing a huge problem with vitamin D deficiency coming out of the pandemic. As you know, we get vitamin D from the sun. We all had a lack of sun exposure for a prolonged period of time. And we all do lose some vitamin D in the winter months because our vitamin D decreases when we're not exposed to the sun. And, if you're not taking an over-the-counter vitamin D supplement in addition to a one-a-day vitamin, chances are the vitamin D is slipping down and could be chronically below 30. So vitamin D normal ranges between 30 and 100. So anyone with no trauma but foot pain, particularly bone pain in the feet, I recommend checking a vitamin D level. And if that vitamin D is low, then prescribing a weekly supplement. We generally do 50,000 units of vitamin D weekly for 12 weeks and then recheck the vitamin D levels to be sure that they've normalized and continue that supplement until they do. Increase in body weight, of course, can lead to stress fractures, more stress on the bone. Think about vitamin D, back to that for 1 second. Think about vitamin D as what creates rigidity in bones. So I often compare this to different types of sticks from a tree, right? A wooden stick, depending on the flexibility of the stick, you don't always know until you pick up the stick. So if you pick up a stick and you start to bend it, if you're not able to bend it at all, it is very rigid. That is what a bone with normal vitamin D would feel like. It's rigid. When you stand on that, no matter how much weight you're carrying, that bone is not bending. That's ideal. When you start to get into vitamin D deficiency, think of a stick that's more flexible. You're able to bend that stick and even splinter it at the top of the bending part of the stick. And that's a bone under duress, especially with vitamin D deficiency. When you stand on it in the metatarsals, in the forefoot there, that bone will bend and can ultimately have those tiny cracks like that stick would. And what you see on the x-ray is exactly what we're looking at here on this film, which is some cloudiness around a part of the metatarsal, which is that small tiny breaks in the metatarsal from bending, and that's often related to that vitamin D deficiency. So again, very important. So treatment for stress fractures is immobilization. You want to take the pressure off of the foot and let that bone heal, and then vitamin D supplementation. The length of immobilization really varies depending on the pain level and the amount of stress reaction on the x-ray, as well as the vitamin D deficiency. If there is any pain after 4 weeks of boot immobilization, that patient is not ready to wear a regular shoe quite yet. They really need to be continuing to immobilize it until the pain is gone. Okay, next slide, please. We have a question coming in from the webinar chat, but we'll be answering all the questions at the end of the presentation. Okay, so this is case number 1. This is my only case. This is a patient of mine, a 54-year-old firefighter. He's an obese patient and pre-diabetic. He presented to his primary care doctor with medial ankle pain with walking, worsening over time for about 3 months, and now is causing a limp. On his physical exam, he had unilateral arch collapse, one very flat foot, one not so flat foot, his right foot much flatter, and pain and swelling along the posterior tibial tendon. He had gastroc equinus, which means a tightness in the back of his calf, and an inability to do a single heel rise on physical exam. He was given anti-inflammatories, and that partially relieved the pain, but not completely. X-rays, not very helpful with posterior tibial tendonitis because it's a soft tissue issue, and so they just showed flat feet, some osteoarthritis, but no fracture. So the treatment initially, as we discussed, was a cam boot immobilization for 4 weeks, which did help. Also, we put him on light duty, which is a big factor in this, is discussing what exactly this person does for a living and what that entails in terms of what they're carrying, how much they're walking, what shoes do they wear while they're doing this. And for firemen, they really need a break when they're having a flare-up of tendonitis, so light duty. And that did help, but not completely. He had an MRI. So we generally order an MRI for posterior tibial tendonitis after the patient has failed conservative therapy for a few weeks, because generally, if they've worn a boot and the immobilization in that boot did not provide relief of the tendon pain, likely there is a longitudinal tear from chronic stress on the posterior tibial tendon, and they do better with cast immobilization. And so that was the next step for this patient, cast immobilization and physical therapy, but still ultimately failed to relieve his pain. So the final step is arch reconstructive surgery. So this is an example of someone who just could not get better with all types of conservative care. Next slide, please. So these are preoperative x-rays showing pes plano valgus, flat feet, and no stress reactions, mild arthritic changes in the rear foot, but nothing that you wouldn't expect to see in someone who works on their feet. Next slide, please. These are the postoperative x-rays. So this is a standard flat foot reconstruction where we add grafting, bone grafting in the rear foot to change the alignment of the rear foot so that when the heel hits the ground, it's no longer hitting the ground on the medial aspect, and thereby the ankle's no longer rolling in and overstressing the medial ankle where the posterior tibial tendon is. And then what you see in that hardware there on the medial column is just further stabilizing the arch to create like a nice solid rectus arch. We call it a tripod, where the heel hits the ground and the inner and the outer border of the forefoot hit the ground equally at the same time, to share weight across the whole foot so that no one part of the foot is overworked. And this patient did quite well after his surgery and is back to his heroic job. And that is it for me.
All right, thanks, Dr. Gilden. I'm going to be taking over from here on out. So I'm Dr. Shoup. I am another one of the podiatrists here at Kaiser. I work at both the Kensington location and the Largo location. I do have a background in traumatic foot and ankle injuries, and here I specialize in reconstruction of rear foot and ankle and sports medicine. So briefly to run in, I'll be going over two injuries today. One is the most common one you guys will see, which are ankle sprains. And then following that, we'll discuss a more severe but less common injury called a calcaneal fracture. Next slide, please. So ankle sprains are the most common foot and ankle injury, especially seen in our young or currently active folks. In this case, military first responders, very common. Clinically, the most common, or 90% of ankle sprains that you'll see in your office, are inversion injuries, meaning that there's a twist inwards and therefore having an injury on the outer side of the ankle. Significantly less common is an eversion, or where the patient experiences pain to the inside of the ankle. Oftentimes these folks come into your office with or without the ability to bear weight. If it's an acute injury, then most commonly within the first day or so, patients say, I really can't even stand on this thing. Everything just hurts. So on the physical exam, what we're looking at and identifying in these, in the diagram here, is the ATFL, which is the anterior talofibular ligament in the front. This one is the most commonly injured ligament throughout, and oftentimes it's even believed to purposely tear to protect the ankle joint itself. Sole sprain or stretching of this ligament would be considered a grade 1 ankle sprain. The CFL goes from the fibula down to the calcaneus. This is directly under that ATFL ligament. This, in addition to the ATFL sprain or tear, would be a grade 2. And then grade 3 would be involvement of that posterior talofibular ligament. This is far less common, I would say. The other portions to be palpating on your exam on the lateral ankle are the peroneal tendons, which are the tendons that run right behind the fibula and insert down into what's called the styloid process, or the 5th metatarsal base. And then also palpating the 5th metatarsal base itself, as oftentimes with inversion injuries, you can have an avulsion fracture here as well. Looking at the medial aspect of the ankle, the area to palpate would be the deltoid ligament, which is essentially the medial ankle ligament that goes from the medial malleolus down and through the talus, and palpating the medial malleolus, or that medial ankle bone itself, as well as the navicular and, importantly, the anterior medial aspect of the ankle joint as well. And next line. Thank you. So treatment for these, we typically follow what are called the Ottawa rules, which were rules created in Canada, that if on your exam, one of your patients is experiencing pain to the medial or lateral malleolus, so those bones themselves, the navicular bone or the fifth met base bone, then you should definitely get an X-ray on this. The other indication for a patient to get an X-ray from an ankle sprain would be the inability to bear weight. But in general, if it is a tenderness along a ligament, the X-rays themselves don't give us much information and therefore may not be necessary. You guys have probably heard of RICE protocol. It's now actually been expanded to PRICE protocol in the setting of ankle sprains. So the additional P stands for protection. The best and my personal favorite way to protect these ankle sprains is with one of those athletic lace-up ankle braces that laces up the front and then has stirrups that loop around the ankle. This, in addition to wearing a sneaker, still lets the ankle joint move up and down, but it limits that side-to-side stress that puts pressure on these ligaments while they're still healing. If the patient has significant inability to bear weight or significant pain, then upgrading the immobilization or the protection to a cam boot helps completely take out all movement across the ankle and the foot and stabilizes it at 90 degrees. R stands for rest, so limiting activity for 24 to 72 hours after an ankle injury is indicated. Ice, especially within these 72-hour windows, should be applied for 20 minutes at an hour, typically at least 4 times a day. If patients have significant swelling, C and E are compression and elevation. So either an ACE wrap or a knee-high compression sock, which can even be worn under a cam boot or under a lace-up ankle brace, help with any additional swelling throughout the ankle. After that, we do try to move these patients into activity. So it's now what we call functional rehab. So at day 3, we let the patient start bearing weight and start getting into motion. The reason being is that if these patients stay stiff or immobilized for too long, it can prolong their recovery significantly. So sitting down, if they are in a cam boot, we have them remove the cam boot and begin up and down motion across the ankle and gentle side to side if tolerated. This just helps start loosening up and moving these ligaments. They can begin protected weight bearing at this time and slowly increase their activity as tolerated. So some folks who have just a grade 1 ankle sprain might be back into activity and walking and everything within those first 3 days or a week. If it's a more severe ankle sprain, then it can take a few weeks for this, but slowly over time, getting them up, getting them moving and back into activity. Finally, incorporating strengthening exercises or therapy exercises as tolerated. So that is the next step to progress them back into their original activity prior to the injury. When we recommend a referral over to us in podiatry or an MRI for advanced imaging would be if your patient that comes in still really is struggling putting weight on the foot after 7 to 10 days and their x-rays are negative. Any patient, even on the initial exam, if they have pain medially, they should be seen by us. Or if they have persistent pain laterally over those ligaments after about 4 to 6 weeks. Finally, patients that come into your office, which we see often as our first responders and our military personnel that have a remote history of an ankle sprain a long time ago and say like, hey, even training now, I'm having more than 2 ankle sprains a year. What can we do about this? Those are the types of patients that these ankle ligaments have healed in a stretched out position or have healed torn. And therefore they just don't have the instability, or they don't have the stability across their ankle that allows them to keep their foot supported under their ankle. So these types of patients often would require advanced physical therapy and occasionally even surgery to help stabilize the area. Next slide for me. Moving on to a calcaneal fracture. So the calcaneus is the heel bone. This is one of the most severe, potentially detrimental fractures that a patient can undergo. So typically these patients clinically present from a fall from a height. On physical exam, there's inability to bear weight. They have significant pain, even pain with squeezing the heel bone medially and laterally, and obvious edema and ecchymosis around here. The reason that this is important is that any traumatic injury like this, we always want to evaluate for compartment syndrome. So whether that's in the doctor's office with our docs out there, or even on the field, if you have a mate that's been injured, what we're looking for is pain out of proportion. So significant pain, even with light touch of the skin that just doesn't quite seem normal. Pallor, which means that the foot is cold, or if you squeeze the toes, the capillary refill is absent to the toes. If there's any immediate numbness in the foot itself, or pulselessness, meaning that you can't feel a pulse. If you're in the emergency department or in the doctor's office, please check a Doppler, because sometimes not being able to palpate your pulse is just because of how much swelling occurs after these injuries. And then finally, paralysis. So if for some reason the patient now can't even wiggle their toes, or when they wiggle their toes, they experience excruciating pain in the foot. Compartment syndrome can be serious because it means that there's a significant swelling trapped within a compartment. This can either be from bleeding or just general injuries, and these compartments need to be surgically released immediately to salvage the functionality of the foot and the muscles. So on radiographs for these folks, foot x-rays are most important. They'll diagnose almost immediately a calcaneal fracture. If one is noted, the next step would be a CT scan. And this is just for surgical planning to help us, preemptively decide how we are going to fix these fractures. Finally, I would always recommend a lumbar spine x-ray. Oftentimes the ground reaction forces when you hit the heel bone dissipates up into the body. And a significant portion of these folks do end up having lower back injury associated as well. Treatment for this, so baseline treatment would be a posterior splint with a compression dressing that's well padded. This just allows for the swelling to go up and down over the next few weeks while being immobilized. These patients are immediately non-weight bearing and are to remain non-weight bearing, and then should be seen by us in our clinic within about a week. All right, next slide for me. So this is our second case for the day. 24-year-old male in jump school deployed his parachute late. He ended up landing feet first and noticed immediate pain to his heel and was immediately unable to bear weight. So because of this, he was transferred to the emergency department. His physical exam there noted pain with the calcaneal squeeze. He had edema and ecchymosis or bleeding, bruising within the area. We did check for his compartment syndrome, so he was neurovascularly intact, able to wiggle his toes, and the rest of his body scans were negative for other injuries. So this is his fracture that you guys can see. Looking at the heel bone itself, there's multiple comminuted fractures. His fracture in particular extends into what's called the subtalar joint, or that joint right below the ankle. And again, his lumbar spine was negative. So the plan for him, he was placed in a posterior splint. We did get a CT, and then we followed up with him in the office. Next slide for me. So once his skin and the swelling had come down where it was safe enough for us to do surgery, this is how he was fixated. you can see on the CT scan that even though these x-rays don't look, or potentially don't look that bad, when you get a CAT scan of these guys, there's multiple fragments along these heel bones, and that's what makes them so difficult to rehab, is trying to pick up all these pieces and put them back together and give them a good functional foot that they can continue off of. All right, so that concludes my part of the presentation.
Awesome. Thank you so much. This was such great information. On the next few slides, we will share with you some links to where you can find additional resources on the veterans page. So on the next slide, please, we can see the link to our Mid-Atlantic Kaiser Permanente military and veterans healthcare. On the next slide, we have information specifically for veterans and first responders, resources that are available specifically around mental health. And finally, on this last slide, we have information specific to the talk today, where we have information on many of the different things that were discussed that you can either share with your patients, or for our Facebook Live audiences, please feel free to access these to get additional information. So now we're going to transition to some of our questions. Thank you so much for those of you who have submitted the questions. I just really quickly, in a few seconds, want to go over some of the things that I heard today and really just take homes for me. I think from Dr. Khan Arthur, really focusing on the fact that there is no quick fix, and most of us would like quick fixes for everything, but especially in people who are in tactical medicine, people who are first responders, military service members. You know, opioids should be the last choice, and we really should look at long-term solutions that will help them ultimately be able to have a fulfilling career, rather than short-term fixes that may end up ending their careers. I love the supportive shoes analogy and our feet not knowing if we're at home or not. And so making sure you're wearing supportive shoes at home. I think many of us make that mistake. So we're careful with the shoes that we wear outside of the house, but that's a good reminder of the shoes to wear at home. I think, you know, the pinpoint pain for stress fractures, that's a good thing for us to know, especially for those of us that are parents out there and our kids play sports. Many times I, as a physician, will get called to be asked if someone has an injury that needs to be further evaluated. And I usually have no idea, because as an OBGYN, this is not my area of expertise. So having this information is really helpful. The vitamin D deficiency, a good reminder for all of us. And I love that stick analogy. That's something that I'm going to take away and think about. I like, you know, rice. So all of us grew up throughout our lives thinking about rice. So rest, ice, compression, and elevation. I really like the P prevention as part of that, and a good reminder to all of us to really think about the supportive shoes, exercise, you know, stretching and working up our level of exercise in order to prevent a lot of these injuries. So really quickly going to some of our questions. The first one, I think Dr. Golden, you answered this, but we'll ask it again. You know, in terms of timing and decision-making around using advanced imaging for overuse injuries, when would you recommend a physician order, you know, the advanced imaging, and or do you just recommend that they refer to podiatry?
I do recommend that you refer to podiatry, especially if you've tried, you know, recommending supportive shoes and rest and taking some light duty time at work and the pain is still persisting. Then the next step is immobilization, which we would do anyway in the podiatry office, and then we would take it from there with advanced imaging if needed.
Awesome, thank you. And then I think this is for Dr. Shoup. How would you distinguish various grades of ankle sprains on a clinical exam?
Yeah, so if they have tenderness over the ATFL, that ligament in the front, that is just considered a grade 1, which most of those patients can just continue to walk and it'll get better over the next few days. If it adds up where there's now 2 or 3 ligaments also added into the mix, that's when we have a higher grade 2 or even a grade 3 injury. Those are the folks that are going to take a little bit longer to heal. Would consider the ankle brace and even the cam boot to offload them and to protect them.
Awesome, thank you. And then, and maybe I'll start with Dr. Shoup, but also Dr. Golden. How do we get a lace-up ankle brace and sneakers or cam boot? Where are those? Is it through your primary care department, or where would you recommend?
I can take care of that. So it's best in podiatry anyway, if you just know what the patient needs. They need a cam boot, they need an ankle brace. Ankle brace, you can just tell them to buy one on Amazon. I mean, we have a standard ankle brace here, but it's very basic. It's a lace up ankle brace with stirrup straps on the side. So any ankle brace is good, but if they're here, you know, we can of course dispense them, but I don't think they need to make a special trip to the podiatry department for just an ankle brace. Now for a cam boot, if you put in a chart review to podiatry, we can facilitate the staff in the podiatry department to call the patient and have them come pick up the boot.
Perfect, thank you. And then this is a very specific question, but I think, you know, we're all thinking about prognosis. And so for someone who has an avulsion fracture of the fifth metatarsal, what is the prognosis? And what do you currently recommend?
So, you know, really avulsion fractures can vary. Typically, they can be treated non-operatively, either in a boot. If it's a very small one, occasionally a surgical shoe. But looking at the x-rays kind of helps determine the degree of the fracture and, you know, what our healing potential is. But the vast majority of these avulsion fractures heal on their own in about 6 to 8 weeks.
Awesome. I know 6 to 8 weeks can seem like such a long time, but you know, I think one of the key takeaways from today is making sure that you give enough time to allow for the, you know, healing and recovery from the initial injury. Otherwise, you set up yourself for ongoing injuries in the future. So thank you guys. I always learn so much from you and really appreciate the time that you've spent with us today. Dr. Khan Arthur, Dr. Shoup, Dr. Golden. Thank you very much to our Facebook Live audience. We appreciate your time and engagement. For our physicians and staff, just hang on and we'll give you some information on SAMI credit.
All right, thanks for having us.
Thank you.
Thank you again to all of our MAPMG physicians, our MRPA members, and of course our KPMAS nurses who have joined us for today's activity. In order to make sure you can claim your credit, our MAPMG physicians and MRPA members, please make sure you log into the MAPMG learning management system and do a keyword search on ankle to self-enroll and complete your evaluation by November 22nd. And to any of our nursing colleagues who have joined us today, the link to your evaluation has been included, and please be sure to complete that as well by November 22nd. This concludes today's CE webinar presentation. Thank you all for joining us.